chairperson, huge appreciation and thanks to Dr. Amitabh and Medicom team. This is a bit offbeat topic, a journey through atypical diabetes, and you are missing it, I think, in day-to-day clinic. There is a good saying, happiness is found along the way, not at the end of the road. Why I am saying this? Because each step which I am going to say through or to discuss, enjoy the that test. Because you know you are listening since long and your brain has become fatigued. Atypical diabetes, if you see someone from this place, he says it will be raining already. So, like that, not all type 1 and type 2 cases, or not all diabetic cases are same. But if you have got some idea of atypical, he will say that it is raining, you like to be, I can see from here, but reality you can see what is the reality. With that background, today we are living in the mindset of either type 1 or type 2 diabetes. But remember, it aggregates that account only for 90% of cases. So what are the 10%? 10% can be grouped under what is it? I think even the latest diabetic care is so a very good article as atypical diabetes. And it is very, very important that we must have some idea about that because it is very, very challenging. So this could be due to so many things. But what is atypical diabetes? It is increasingly acknowledged that the traditional binary classification of the diabetes into type 1 and type 2 falls short in observing the diverse metabolic and clinical phenotypes, molecular mechanisms, and release pathway that connect in hyperglycemia. So, atypical diabetes is suspected in individuals who do not nearly neatly fit in the currently accepted criteria of type 1 diabetes, which you know, and type 2 diabetes or secondary diabetes. So that cases becomes a spectrum of clinical diabetes. Could be insulin resistant, lipodystrophic, syndromic, monogenic, mitochondrial, Ketosis-Prone Autoimmune, and in our clinical practice, most of time we are missing it. Because research paper says, when I told you in the 2024 diabetes care, 5 to 11% based on ethnic and other population associated factors, prevalence is not less. So it is quite important. And you can see in diabetes, what is happening in diabetes? You have got insulin sensitivity factor, Latent Autoimmune and insulin. Apart from that, in around involving many things, and that becomes atypical cases. So how let us see how we are suspecting. When you are going to suspect, in this case is not type 1, not type 2, this is something else. I think this is very easy to me. You see the disease code because you are not paying proper time for the history. Just take the history of a diabetic patient. Is this atypical natural history there? What is suppose patient is taking insulin? What is the idea about the idea of the insulin requirement? It is justifiable or not? See the how early or how late the complications are coming, rapidly progressing or slowly progressing. Is there a history of frequent pancreatitis or decay with subsequent insulin independence? Suppose some patients will come with a decay, 48 or 50 years old case. But later you find when ketone was positive that time, you treated a decay, but later you find there was no need of the insulin. So think about that, there is something else here. And also family history is very, very important. And then you go for the signs of physical reaction, signs of insulin resistance. If there is a ketosis, adipose tissue loss. You see the muscle. If there is some loss of the adipose tissue or syndromic features, and this will give you the exact idea of what is happening. And then you think about the diagnostic tools you are going to do, the autoantibody, C-peptide, lipid panels, and other things, or genetic panels. So I told you that these tests of islet autoimmunity, you are well aware about the GAD antibodies, IA2 insulin and gene transporter 8 antibodies, so insulin antibodies, or then you also accordingly you think about the insulin, serum insulin or C-peptide levels, and sometimes you can need OGTT. And then there are lots, suppose that you have a strong family history, young patient. So you have got to think about the monogenic diabetes, and there are many online tools are there. The best I think is the extra MODY calculator, which is available online freely. And then pancreatic diabetes and insulin resistance form. Now see this case. 12-year-old female coming with history of decreased activity and increased sleeping at 4 months of age. So she was diagnosed as diabetes at the age of 4. But you are seeing at the 12 years old, she had no polyuria, polydipsia or weight loss at the time. Her blood sugar was 535. So she was diagnosed with type 1 diabetes and put off insulin at age 4. So this is the initial history. What happened later? When she became 11-year-old, some physician took a detailed history. Oh, there was developmental delay and lots of things, and found that there is a developmental delay, epilepsy, and definitely this was a neonatal diabetes. And then a genetic panel test was advised, and it was found that we are well aware about the KCNJ11 mutation. And then what happened? She was subsequently shifted from insulin to glibenclamide at the dose of 10 mg TID, that is a dose of neonatal diabetes. And her HbA1c came to 5.5. So from the age 4 to 411, she was on insulin. But when a typical diabetes was diagnosed, there was put on the OHA glibenclamide. So this is the magic of diagnosing the atypical diabetes. Like that, final diagnosis was monogenic diabetes with KCNJ11 presenting a GAND syndrome. There was developmental delay, epilepsy, and neonatal diabetes. And this is Lilly, law of Illinois in USA 2010, very famous case, poster girl of precision medicine by monogenic diabetes engineer. This case again was like that, where a 6-year-old Jeffrey had developed diabetes at the age of 6 months. From 6 months till she was diagnosed as monogenic diabetes, she was on insulin. So it was made a law in USA that whenever you find a case that it is diabetes had developed in the neonatal period, that is 1 year of below 1 year of age, go for the genetic panel. And if it is suffering from some genetic like mutations, it only requires the overall given limit of the family. And he is I think, the very famous person who diagnosed this case, Professor Andrew McKenzie. And I was going to educate also at DSD. And he is telling that 93% of patients with monogenic diabetes are not recognized. They are misdiagnosed as having type 1 or type 2 diabetes and receiving the wrong treatment. So I think this is a very, very important consideration that in diabetes also. So this is the recent photograph of that letter. Now see this case from the Canada. A 4-year-old and then 4-year-old boy and then a father was diagnosed with type 1 diabetes. She was diagnosed. This boy was also diagnosed with type 1 diabetes, and grandfather Tom was also diagnosed with type 1 diabetes when he was at 21-year-old. But when someone took the proper family history and went for the genetic panel test, all were suffering from monogenic diabetes. And they all were shifting from insulin to sulfonamide. So this is the magic of monogenic diabetes. That you know how this works. Then there are other forms of oligogenic diabetes where there are so many genes are there. Now this 25-year-old, like next case, 25-year-old man explains that he had diabetes since 17 years old. Father and his only brother also giving a diagnosis of diabetes in late teens. And all were initially claimed to have type 1 diabetes. The diagnosis is certain given their young age, lean build, and white ethnicity and no sign of insulin resistance, which would have suggested type 2 diabetes. But what was here peculiar, that patient insulin dose has already been very low, less than 10 units per day, with no basal insulin needed. Suppose in the case of type 1 diabetes, this is not matching at all. So his fasting blood glucose is usually below 110, and he was able to miss insulin dose sometimes. And even if he eats low carbohydrate meals, he is prone to hypoglycemia when he increases insulin or he is exercising. So what was done? There were no decay episodes. And then again a genetic panel test was done and found to be a case of HNF1A monogenic diabetes. So what is the take-home message from this case? He has an unusual form of diabetes that is strongly inherited. You saw the history. Genetic testing of HNF1A mutation is commercially available. It can offer to confirm the diagnosis. He can be switched from insulin to a low-dose oral sulfonylurea. So this is how this. So whenever you see a strong multi-generational history of early onset diabetes and presently requiring minimal requirement of insulin, optimal fasting glycemic control, and there is no history of decay or kind of insulin resistance, his father has responded very well to low-dose sulfonylurea therapy. So you can easily go for genetic panel test, and in India it is not an outreach because many centers are also doing free. Like if you email to Dr. Mohan, his center does the whole genetic panel test free. In the same way, there are lots of cases to diagnose like this, but I know it is not possible to show you all. But even in some cases, like this case, you can see that the present maternal grandfather, grandmother, and then a 13-year-old boy diagnosed with diabetes at the age of 8 years and started on metformin, which was gradually increased to 500 mg daily, which remained stable around 6.5. But family history was again remarkable for multiple maternal relations with diabetes, and in this case, again, a genetic panel showed that it was a GCA gene mutation, and it was relevant to attempt discontinuation of metformin. तो उसको जो metformin दिया जा रहा था उसको भी बंद कर दिया गया. So this is also very important, which you can diagnose GSK MODY, and I think if there is some find something like urinary disease cases, like sometimes you get HNF1A or also GSK. So this is message is quite clear. So whenever there is onset of non-obese diabetes occurring in young age, there is no sign of insulin resistance, there is history of diabetes at least 4 generations, you know this, seen in younger person less than 25, if you go for autoimmune, they will back, and autosomal dominant transmission, I think you must think about that you back something, MODY you are going. And there are so many overlapping diabetic symptoms also there. Then the LADA is also known as atypical diabetes. I am not going to details of the LADA, but this is usually presented in adulthood as slower progression towards an absolute insulin requirement. And basically, when there is GAD antibody positive, you can diagnose this case, such cases with this. So, if there is a history of adult age of onset more than 30, presence of any item from the autoantibody, and there is absence of insulin requirement for at least 6 months after diagnosis, think about the LADA. Then again, there is a spectrum of secondary diabetes. I think recently we discussed this case about the pheochromocytoma leading to secondary diabetes. So if there is, remember these all things. If you get features of these things, think about that this is not a normal diabetes, it is a secondary diabetes. And lots of cases you are getting with history of pancreatitis, calcification in the pancreatic duct, such cases like type 3C diabetes, and this is also a different form of diabetes, ketogenic diabetes. So this is also a atypical diabetes. It is very unique. And then there are many syndromic diabetes, very different cases, some I think we are not going into detail of that. But see here, the patient has coming with this such hand, such color, chronic diabetes, like a 51-year-old male, family history negative for diabetes. And you can see the BMI and other things, but What is important here that erythrocytosis was there, hemoglobin was 18.6, and in this plasma creatinine was quite high, saturated transforming factor more than 54%. Such cases you are diagnosed with a case of hemochromatosis. You can do the genetic analysis again here for HSV gene and such cases which is known as Crohn's diabetes. And also there is a typical diabetes, many cases like cystic fibrosis related diabetes. Then there is also very important things you are getting details is type A insulin resistance syndrome, where there is insulin receptor gene mutation, like patients coming your patient with polycystic ovary syndrome is severe hyperandrogenic necrosis and marked insulin resistance, which is known as type A insulin resistance syndrome. And if type B is there is immunoglobulin G antibody directed against the insulin receptor, it becomes type 2. So many such cases you are getting. Like it is 13-year-old female, necrosis, multiple skin tags. And on follow-up, you can see here that non-fasting insulin was elevated, insulin to C-peptide ratio was raised, and estradiol pressure was normal, testosterone was elevated, LH and FSH was normal, vaginal ultrasonography revealed polycystic ovaries. And again, in such cases, when there was a screening of insulin receptor gene that prevented electrolyte mutation, so even such cases are very sometimes you are getting. So this is also some cases of the type B insulin resistance syndrome, the rare disorder that is caused by the autoimmune diabetes. And again, there are some features typical of these things. Now I want that time talking about the KPD. Many cases we are getting in our clinical practice. Even at Dhanbad, I have lots of cases of KPD. Ketosis-Prone Diabetes. Patient coming with the diabetic ketosis. But many times the guide antibodies in island control negative, and later the insulin requirement was nil, at least nil sometimes, because in such cases it is termed as a typical diabetes of ketosis-prone type 2 diabetes. It is a new clinical entity under the typical diabetes, also known as flat plus or erythroid diabetes. So these individuals present with severe hyperglycemia and ketosis similar to type 1 diabetes, but they have clinical and biochemical features typical of type 2 diabetes and can discontinue insulin and maintain acceptable glycemic control on diet and volume. So think about also that. I'm not going to tell how the ketosis resistance and how there are so many types of A plus, B plus, A minus, but to tell you this is sufficient that you can diagnose such cases as ketosis-prone type 2 diabetes. Then there are some differences in the LADA KPD. Then also sometimes you will get double diabetes or hybrid diabetes presenting in childhood and adolescence. Some there will be some category of type 1 diabetes, positive diabetic associated autoantibody, and type 2 diabetes. Features are also like obesity, insulin resistance. So also we are sometimes getting double diabetes. Lastly, what is this case? Is it Cushing? Recently presented at our JGS5 webinar. This case, 15-year-old female. She was diagnosed having diabetes 1 year. For 1 year was on irregular treatment, anorexia, and then eruptive gianthoma. You can see here, fasting was 420, 490, HbA1c 60, but urine acetone negative, cholesterol so high, and fasting insulin was high, fasting C-peptide was 2.5, that is normal. So such cases where diabetic mellitus at the age at onset, uncontrolled hyperglycemia without ketoacidosis, generalized loss of subcutaneous tissue. So I want to tell you, think about seek for the generalized loss of subcutaneous tissue. Severe insulin resistance, eruptive gianthoma, and hypertriglyceridemia with low HDL and lipoemia rectalis. You can see I told you, and here you can see this case, loss of subcutaneous fat. Such cases are nothing but generalized lipodystrophy syndrome. Many forms are there, so I think the very clinical concepts are quite clear. Loss of body fat, generalized or partial, prominent musculature, sphygmomegaly could be there, veins could be prominent, TG is so high, triglycerides, profound hypertolerability, hyperglycemia driven insulin resistance, severe acanthosis, and think about lipodystrophic syndrome. So lastly, my key points are that atypical diabetes these days we recognize so often the poorly defined and made maturity type 1 or type 2 diabetes. But you, as I told you and I showed you that how it differs the treatment pattern, management pattern if you diagnose these such cases. And the most common with HFF1A monogenic diabetes, MODY 3. So if someone asks you what is the most common MODY type, there are 14 or 15 types of MODY. So this now there is EMA MODY, third time range of the so MODY 3. So here there is MODY 3, so this is MODY 3. This is HLF1A alpha, this is number type. Single gene power diabetes, KPD should be considered in individual with phenotype type 2 diabetes and insulin deficiency and ketosis and LADA controlling chronic autoimmune disease. So I think with all these things, if you give some time to your patient's history and clinical pointers, we cannot miss such cases. And I think I can end here. Thank you very much. Thank you.
Thank you for a nice talk. Any questions, please?